All right. Hello, everyone, and thank you all for joining us for our webinar, Bridging the Gap, Supporting Those with Communication Challenges in the Rehabilitation Setting, presented by speech therapists Sarah Foley and Erin Leary. I'm Spencer Portier, your moderator, and if you have any questions at any time during the webinar, feel free to submit a question in the chat window or as a message, and our panel will try to answer at the end of the presentation. Throughout the webinar, we will have 3 polling questions. Please make sure to answer the questions in order to receive credit. Credit will go to those who have signed on using their email for this presentation. And education credits will be provided by our partner, the CEU Institute, and you will receive an email from the CEU Institute in the next couple of days regarding your credit and how to obtain it. Now passing it over to Erin and Sarah.
Hi, everyone. Thank you so much for joining us. We're excited to have an audience from diverse populations all around our nation today. A little bit about Sarah and I. This would be Erin speaking, and Sarah will chime in a bit. We're both speech pathologists in Craig's Assistive Technology Lab, which throughout this presentation, you'll be hearing about different tools that do involve some technology. So we're lucky to be consulting speech pathologists for all patients at our hospital. And we'll tell you a little bit more about that as we go. As Spencer mentioned, we're going to hold dedicated time for any questions that are left in the chat. So please feel free to put any questions you have in there throughout our presentation. And our emails will also be available at the end of the presentation. So please feel free to reach out to us with any questions or comments. We're happy to have discussions beyond this dedicated time. So by the end of today, we're hoping that everyone feels confident in the definition and importance of what we'll call augmentative and alternative communication, commonly referred to as AAC, throughout this presentation, identifying patients who are at risk for communication challenges, describing ways AAC may assist with treatment and recovery for those patients, and understanding different communication tools that are available across stages of recovery for our patients. So before we get into alternative ways of communication, we want to take a step back and think about communication as a whole. So all of us communicate for lots of different reasons. You may communicate to gain attention from others, communicating your wants and needs to people, whether it's something you want at the dinner table or something more important that our patients may be experiencing, transferring information from yourself to a group of others or one other person, similar to this presentation, maintaining social closeness with those around you, and your standard social etiquette, the please, thank yous, hellos, and goodbyes we have every day. So those are the purposes we communicate, but we also have a lot of means in how we communicate. So talking is the primary one that comes to mind. But we also have other ways to communicate, like writing, like texting, drawing, pointing with gestures, and our facial expressions. So following an acquired brain injury, which is the population Sarah and I serve most often, our purposes for communication remain exactly the same for these patients. The challenge that we often come across is that the means of communication or how they're able to communicate has been altered. So in thinking about your present caseloads, think about how many patients you may have where some of these means are altered, whether they're unable to talk effectively or write effectively. And when thinking about those patients, please include those that do have a cognitive or language deficit. So we're not solely talking about those that motorically are unable to do these things. So after those means of communications are altered, there's several goals to be addressed. One is making sure we're able to meet the communication needs of these folks in the immediate. So are these people able to communicate with their team at the hospital as well as their family? And then additionally, we need to make sure we're working towards restoring those communication tools. Often, meeting the immediate communication needs of patients may only partially be addressed or skipped completely by the nature of a rehab facility. Well, we want to talk a little bit today why both of these goals are immensely important for our folks. So in maximizing all types of communication, talking about why it's important, our gut instinct is likely to lean on the emotional impact and poor quality of life of these folks. Having the ability to communicate and then losing that ability is so important to ethically think about. And there's actually additional information out there that our gut may not jump to immediately. So in this metasynthesis, they talk about how poor communication is associated with all sorts of things, being low quality of care, reduced patient satisfaction, increased rate of adversity safety incidences, which we'll talk about in the next few slides. And articles and research has focused on the populations of all adults in hospital settings in general, the use of AAC tools for adults with disabilities when they are in a hospital communication for adults with aphasia, and hospital communication for adults with intellectual disabilities. So one of the main measures people have utilized to look at why communication is so important is adverse medical events that are occurring. A startling fact from the article shown here is that as of 2016, medical errors became the third leading cause of death in the United States. And so this article discusses how some of those medical errors may be precipitated by communication failures between patients and providers. And to be clear, there can be communication failures for those folks who are able to verbally communicate, but our research has shown that these adverse medical errors are much more present for those who are communication vulnerable. So looking at a set of adverse events, this research out of Canada produced by Bartlett and colleagues showed that patients with communication problems were 3 times more likely to experience a preventable adverse event than patients without such problems. Furthermore, these patients were more likely to have multiple preventable adverse events occur to them while they were in the hospital setting. So keeping that in mind, that those with communication barriers are 3 times more likely to experience preventable adverse events when compared to those with no barriers, not only do these events lead to poor patient outcomes and dissatisfaction, but they're also very costly, which may be relevant to those of you who work on the funding side of our healthcare system. So the displayed article here by Richard Hertig indicated that the annual cost for all preventable adverse medical events reached $29 billion in the United States. And then he further parsed out how many of those preventable adverse events were AAC candidates or folks who could benefit from alternative communication. And just looking at those folks, the cost reduction for the U.S. could be up to $6.8 billion a year had those folks been provided a tool or assistive technology to accommodate for the communication differences. An additional reason why this is important is it's actually mandated by JCAHO for us. So JCAHO clearly states that patients have the right to effective communication, and healthcare organizations need to provide support to achieve effective patient-provider communication to all patients, which includes patients that do have disabilities and require augmentative or alternative systems to aid in effective communication. And last, but certainly not least, and possibly the most important of all of these reasons, is that when you're making sure you're maximizing all communication, your outcomes are improved. So there's a lot of statistics out there indicating objectively why it's important, but reaching back to our gut sense of ethically why this is so important is offering tools when needed increases our patients' engagement and motivation. That directly correlates with satisfaction numbers throughout a hospital setting. It often decreases the burden of family and loved ones when they are the primary advocates. Hearing what their loved one is thinking can take a huge burden off them having to make decisions without hearing that information. And then lastly, at Craig, we utilize this a lot. It provides us information on a patient's present cognitive and communication status. So without having tools to communicate, we really don't know what a person is thinking. So many of our assessments rely solely on the ability to communicate. So we use these tools heavily in order to accurately assess our patients. So moving on to Sarah, she'll talk about AAC specifically.
So Erin has given us the why of to talk about the importance of communication. And for the rest of today, we're going to be talking about how to provide communication options for patients who aren't able to communicate effectively using verbal speech. The term that we use for this, you've heard Erin use already, is called AAC, or Augmentative and Alternative Communication. What you see on this slide is that ASHA, which is the American Speech, Language, and Hearing Association, defines AAC as all of the ways that we share our ideas and feelings without talking. And when you think about what that means, this really means that we're all using AAC methods on a regular basis. For example, if you want to tell someone about a trip that you've been on, how else would you communicate that besides verbally? You might pull out your phone and show them a picture, right? If we agree with someone, how do we respond? Well, if we're in person, oftentimes we'll nod along with them so that we know that they can tell that we're understanding. If we're over text, we might actually text back with an emoji of a thumbs up so that we know. So there we're using a symbol of what we're meaning. So with AAC, even though the term is probably new to some of you, it's certainly not a new concept. We use these things every day, actually, to supplement or substitute for our verbal speech. The difference between us and many of our patients is that we always have verbal speech readily accessible to us. For many of our patients, these forms of augmentative and alternative communication become essential for communicating even the simplest wants and needs. So when we're talking about the realm of AAC, these are some of the various modalities that we're using. So some of these, again, are things that you and I are using, and some of these are specialty things that we introduced during the rehab phase. If we follow along on the left side of the slide, the no-tech options are just that. They're anything that requires no technology or really anything supplemental for a person to communicate. So these include pointing to something that you might need, using blinking to maybe indicate a yes or a no response, nodding, which obviously is the most universal sign of yes and no, use of facial expressions, and using gestures to maybe act out something that is needed. In the middle column, we see that low-tech AAC methods. These can involve both non-electronic and very simple electronic devices. So when we talk about non-electronic modalities, you can see in the picture here, we have a piece of paper right here that just has 4 blocks on it and has 4 basic needs of a person. Behind that, you can see an alphabet board that has the alphabet kind of parsed out in rows and columns that we can use either to have somebody point at, or we can use something called partner-assisted scanning to be able to get them to indicate what letters they want to choose. For electronic devices, if you look up here at the top, there are 2 little buttons. These buttons can be programmed to be able to provide just a simple message, either a yes or a no response. And finally, high-tech devices. These are the ones we're probably most familiar with, using an iPad or a full-fledged computer to be able to communicate something. All of these computers have the ability for speech output, and so whatever a person taps on the screen then will produce some type of verbal speech for them. And then just a note, what's really important to remember is that it's never just one AAC modality. Pretty much any high-tech user also has backup low-tech options that they use as well. So when we're training these things, the important thing is just to be consistent with the types of communication people are using. So we're going to take a second and do a quick poll. So if you could answer this for us, how often do you work with a patient or client who can't communicate well verbally and thus may be a candidate for AAC? If you could just help us understand kind of what your experience is with this. Spencer, is there a way for us to see the results of the poll?
It should be in the dashboard, but I can read it to you if you'd like.
That'd be great. We aren't seeing it.
We have 15% often, 38% sometimes, 34% rarely, and 11% never.
Okay, so a pretty good representation of across the board how many people are using this regularly. Okay, thanks for that. All right, moving on. Okay, so let's get into what populations of people can benefit from the use of AAC. Obviously, here at Craig, we are a hospital that works primarily with traumatic brain injury and spinal cord injury. And all of these categories we'll talk about are people that we treat here at the hospital. Disorders of consciousness is the first group. This term refers to any patient who is in what we consider a vegetative or a minimally conscious state. Erin's going to get into what this means very shortly, so I won't say much more than that currently. Anyone with cognitive impairment, Erin had referenced this earlier as well. So anyone with a moderate to severe cognitive impairment can also be lacking in communication, or their cognitive skills may be impacting their ability to communicate efficiently and effectively. So these patients can also have maladaptive behaviors such as throwing, kicking, punching, hitting during certain phases of recovery. And sometimes having a communication method can actually serve to reduce those maladaptive behaviors. Motor, speech, and voice disorders. These are the things that you probably think about when you think about someone having trouble communicating. It could be someone who has very slurred speech. They could have a paralyzed vocal cord that makes it difficult for people to hear them or to understand exactly what they're saying. Locked-in and brainstem injuries we'll cover at the very end, time permitting. These are our patients who are just that. They are locked into their bodies. So after a brainstem injury, people can have very severe speech deficits, sometimes to the point that they're unable to move their mouths at all. But they remain completely intact with language and cognitive skills. And so AAC becomes essential for this group of individuals. And finally, aphasia. Aphasia very generally is defined as a language disorder that's caused by an injury to the brain, which affects a person's ability to understand or produce speech. And due to the breadth and nuance that is aphasia, we're not going to cover it too much today due to time constraints, but know that because of these communication deficits, AAC is often used to serve people in this population. So we also need to talk about types of communicators. As with most things in the rehabilitation phase, we're always working towards independence with our patients. But most do not start off being completely independent with these AAC methods that we are teaching them. You're not going to be able to hear the audio on these videos, but I'm going to just kind of talk over it so that you can see what is going, or you can understand what's going on. In this first video, you're going to see an example of what we consider a partner-dependent communicator. If you're wondering what we look like, this is Erin, and this is me. Erin is going to be the patient in this video, and I obviously am the therapist, or I could just be a communication partner of hers. And she does not have the ability to speak, and she needs to rely on me as her communication partner to provide her information that will help her communicate in situations. So in this example, you can see on the whiteboard, I've written a question. It says, what's wrong? And then she has 4 choices under there: pain, uncomfortable, tired, and something else. And she is able to point, so she is just pointing at the one. She pointed at pain. And then the next thing that I'm going to do is actually ask her a follow-up question. Erin, where is your pain? Can you show me? Can you give me a gesture to show me where you're having pain? So you see in this exchange, I, as the communication partner, am trying to anticipate some of those needs, and then I am giving her the opportunity to express them in a different way other than verbal speech. And then in this video, obviously, our independent communicators are just that. They are familiar enough with their AAC device that they are able to use it independently. So in this video, this young woman, she's set up in bed, but she has a dedicated speech generating device. So it's a full computer. She has a keyboard on that computer pulled up, and she's using her eyes to go to the target that she wants, and she's using her chin and that little switch that's positioned under her chin to be able to activate on the letter that she wants. So you can see in this example that once she is set up, she is completely independent with what she needs to do to communicate. Okay, so when we start our AAC, hang on one sec. When we start our AAC evaluation, we have to start off talking about access. So how is a patient going to actually interact with these tools that we're giving them? And this is where we as SLPs tend to rely very heavily on our occupational therapy counterparts, because they can give us a better idea of a person's vision and their physical capabilities. During the evaluation process, the goal is always to figure out what kind of movement the patient has that is both consistent and volitional or voluntary, and then be able to pair that with one of the access methods coming up. For physical access methods, we're talking about what different things in their body, or what things can we put near their body that can help them to interact with the AAC device. The most obvious is direct selection. This is using the hand to indicate or activate a choice. If someone is unable to use their hand or a finger to be able to do that, then we can look at other parts of the body. Can they use head pointing or head tracking, or even their eyes to be able to interact with the computer? You can see on this device right here in the lower right corner that this has a head tracking piece up top that will read the head movement based off of a little reflective dot that the person wears. And then down here, there's an eye gaze bar. And this is what can allow, it has software that reads the reflection off of someone's pupils to be able to control the mouse on the screen. And finally, if someone is not able to use any of those modalities, then often we will look at switch access. And you'll see some switches coming up, but switches can be used in a lot of different ways to be able to capitalize on using any small movement of the body to be able to activate one of these devices. We also have to take into account cognitive and visual access methods. I'm not going to get into these too much, but just know that there are lots of ways that we can adapt these devices to be able to be easier for the person to use, especially when it comes to vision. There are many things that we can do with font size and contrast, positioning the device in a particular way that's going to make them more successful. And before I turn it over to Erin, we just wanted to talk about probably the most universal communication need for patients after an injury, and that's the ability to get help when someone needs it. Of course, in our hospitals, it's required that patients have a reliable way to call for help. What we know, though, is that standard call systems are often too difficult for one reason or another for patients to access, either physical, cognitive. And so you can see in the picture on the left, there's a whole bunch of switches that can actually be hooked up to nurse call systems to make them easier for a person to use. In this picture with this gentleman, you see him using a sip and puff call switch, where he can either sip or puff to call the nurse. And these are great options to have in the hospital, but what happens when a patient goes home? Do they have the same ability to call for help that they did in the hospital? And what if their communication ability is impaired? At Craig, we're emphasizing the need to consider call systems for home to continue to offer patients that independence and to reduce caregiver burden. Some examples of call systems are mentioned here. Two of the biggest that we use tend to be monitoring systems. These used to be simple baby monitors that you could either have audio or visual. Now, with the advent of smart home technology, smart speakers, smart video, these are very easy to do, and often people can even have the ability to use their phones to keep track of their loved ones. Wireless doorbell systems, such as this one at the top right, can be used as well, and these can even be switch adapted. So you can get ones where if this button is difficult for people to hit, you can actually plug in any one of these switches down here so that they have a way to get a hold of their loved one anywhere within the house. And the big key on this is that we are doing this to increase patient safety, increase patient independence, and reduce caregiver burden.
All right, so this will be another poll. Spencer will get it started for everyone. There we go. So if you could answer this question, why is it important for a patient or client to have an accessible call system in the hospital and at home? Increases patient safety, increases patient independence, reduces caregiver burden, or all of the above?
Okay, I'll give you another second to answer that question. And again, we can't see the results, but we're hoping everyone picked all of the above. All right, I'm going to turn it back over to Erin now.
All right, so now we're going to get into some case studies where this is relevant for our folks. And we're going to focus on traumatic brain injury since that's the specialization, one of the specialties that we work here with at Craig. But I really want everyone to think about going beyond the diagnosis of a traumatic brain injury. Think about your patients that may or may not have that diagnosis, but are presenting with these similar characteristics. Because oftentimes with communication systems, they're provided to those that are fully cognitively intact, but not those that have some limitations, where we find here at Craig that there actually is a larger breadth of appropriateness for these tools. So we're going to go through the RANCHO levels of TBI, which is the way here at Craig we are able to kind of explain where someone is at cognitively following their brain injury. So starting at the lowest level, levels 1 through 3, this is where you would think of a patient that's in a coma or be described as a vegetative state, or just coming out of those phases and is minimally conscious possibly. These folks are definitely going to be lacking consistency in their arousal levels. So these folks are often in the ICU, in acute care, and just getting to rehab. So what we really want to bring to attention is being aware of the possibility that a person's body or motor profile may be preventing them from really showing their full cognitive profile, or communication abilities. So Sarah mentioned the most extreme version of this would be a locked-in state when someone's cognitively intact. However, what if a person is not totally cognitively intact, but isn't able to demonstrate where they really are at? So the biggest goal for these lower level folks regarding alternative communication is going to be ongoing assessment of where they are at. In addition to that ongoing assessment, there are other goals. The goal to make sure there is a response to the environment. Is a person able to recognize when a change in their environment happens? Can a person start showing preferences or looking at different photographs? Are they looking at a photograph of their loved one more so than a photograph of someone they don't know? And improving that relationship where if a person does something, another thing happens. So beginning to see those really early signs of consciousness, and then with errorless learning, consistently shaping the responses that they are able to have, all while appropriately assessing this person for where they're at. So in showing a case study of this, because what does this look like in real life? This is Steven. He is a 29-year-old male, well, was a 29-year-old male when he was here, and he was in a car accident in September of 2018. 3 months later, he was admitted to Craig, and he is a really unusual case because he was here for 10 months, so that's not a typical stay here at Craig. There are a lot of reasons for that with discharge planning, but what that did offer us is a lot of time to get some really good information and data. So typical for this stage in a brain injury, Steven really struggled with arousal. Day by day, hour by hour, his wakefulness looked different. And he had no clear motor profile of how he could communicate or do anything to command. A lot of time at this phase, we're looking to see if someone is able to follow a simple command. While he would not be considered locked in since he had much more movement than just his eyes, we really had to work with our occupational therapist, seen up here, of what motor movement would be the best to take advantage of, even if none of them were really ideal. So a common way that we assess a coma recovery is the CRSR. It's an assessment here that's used as a gold standard for determining someone's cognitive status. One of those subtests within it is a communication scale. And what I think is interesting here is Steven consistently was getting 0 on this scale. In this scale, people ask a yes-no question 6 times in a row with varying answers that are correct, yes or no. These buttons, the primary SLP, Allison, who's wonderful, decided she wanted to trial something a little different. So we provided Steven with these buttons mounted where he could use his finger to toggle between yes and no. You'll notice on this graph, all of a sudden, Steven's scores went up. That was the very first day we introduced those buttons. So at baseline, we were thinking he probably does not have the ability to communicate effectively. And then as soon as he had the correct tool, the decisions there became different. Now, more important, this information is in the acute care setting where physicians are determining prognosis of your TBI patients, trying to educate families on where that patient is at. This could really change something. Here at Craig, this data did impact medications that Steven was receiving and other decisions. Just as important are with a lot of education to Steven's family about accuracy. You'll notice it's very variable with the hard objective data. This also gave Steven's family a way to communicate with their son in some form to get an idea of what their son may or may not be thinking at that moment. Not to give the wrong impression that he was accurate 100% of the time, all day, every day, but in certain moments, he proved to us that he was in fact aware of things happening, letting us know what kind of state he's in. So moving along, the RANCHO levels 4 through 6. So these are the patients where we're thinking are certainly confused. Sometimes they're agitated, sometimes they're inappropriate. All the time they're going to have decreased awareness of their communication deficits and their overall deficits. So these folks are either not oriented at all to person, place, time, or very infrequently oriented. That's more at RANCHO level 6. So our program here feels extremely strongly that despite a cognitive impairment, patients have the right to communicate. So what I want to just point out is, yes, sometimes that communication may be deemed inappropriate, but you have to think, if this person was a verbal communicator, what would they be saying? And we really need to give everyone the opportunity to do so. For ease of time, we'll skim through the overall goals, but we do things as basic from wants and needs and information to participating in conversation. And for folks that do have that agitated level of, are they trying to communicate something with that agitation? And can we provide a better way to communicate that? I had a patient here just a few weeks ago who was throwing items in his room because he wasn't able to communicate if he needed something. So he felt like that was the most effective way to gain attention, where very quickly providing him a verbal button saying, hey, can you come here, decreased those behaviors. So one case study for this is Apollonia. Here she is in the top right corner. That photo was taken last month. And here she was when she was an inpatient with us. She was 19 when she was in a car accident and admitted to Craig 4 months after. When I met Apollonia, she had a system for yes and no, which showed some sort of language skills. Not all of these folks are able to understand yes and no questions, so that was a great thing for us to know. Her system was challenging, though, because she was holding up fingers, 1 for yes and 2 for no. But that was really, really challenging for people to clearly know what she was saying, unless you were very familiar with her. So upon evaluation, we looked at some spelling skills, and she showed us some really interesting things. She was able to spell 3-letter words only with letters presented on her right side. Of course, there was a left neglect present, which we had to accommodate for, but she did show us her literacy skills in that way. She started out only being able to do 2 options of written choice communication. For example, in OT, do you want to stretch or go on the bike? And she would select. Oops. Very quickly, she moved up to being able to handle way more than 2 options. And we added yes and no symbols to her whiteboard so everyone could understand what she was attempting to communicate, rather than her 1 finger up or peace sign. At this time, she did not have enough head movement to indicate yes, no's using typical nodding and shaking of your head. A few weeks after, and through consistent assessment of her cognition, she was able to spell out full words using this tool with a key guard on it. This is a dedicated device, but also can be utilized as an iPad. Apollonia was spelling as long as we cued her to find the red tape first. Now, unique about her is when she left Craig, she was still unable to answer open-ended questions. So if you said, hey, Apollonia, what did you do this morning? Or how are you feeling right now? She would respond, IDK, I don't know, to every question you asked. However, if the communication partner was trained appropriately, if you said, hey, Apollonia, how are you feeling? Great, okay, or terrible, she would type out which one she wanted. She left us after about 3.5 months, still in PTA, disoriented. I'm happy to report that I still get to see her as an outpatient. So 1 year and 7 months after her injury, she's now oriented, laying down new memories, and responding spontaneously on her dedicated device. And we are working on social interactions. So she has come quite a long way. Now I'm going to pass it off to Sarah to discuss Oh, I guess we're going to have a poll first before we pass it off to Sarah. All right, so the poll. What are some common AAC tools used with partner-dependent communicators? So folks that require a partner to help them communicate. And we're just going to give a minute to everyone to respond and get their credit for attendance here. All right, so we can't see everyone's response, so we're hoping answers were all of the above. All right, now on to Sarah.
Okay. So Erin actually left off at a really nice place talking about where Apollonia is now, where she was talking about her being out of what we call post-traumatic amnesia, which means she is now remembering things day to day. That is a nice segue into RANCHO levels 7 through 10. So these are the highest levels on the RANCHO scale, and really the hallmark of this group as compared to the group that we discussed before it is just that these people are now out of post-traumatic amnesia, which means, again, that they're starting to lay down new memories. It does not mean that their memory's perfect. A lot of these people still have very significant memory issues. However, they are able to start to learn new skills that are being taught to them. And so in this group, we often see people moving from a partner-dependent state with their AAC into a more independent state. At this level, people can also have all sorts of cognitive deficits. These are sometimes the more subtle cognitive deficits of slower processing speed or difficulty with decision-making or executive function. But really the key one for us to think about is how having the ability to lay down new memories can start to make these people more independent. The common language and speech deficits that you see here are dysarthria and apraxia, so something that is inhibiting them from being able to communicate clearly and effectively. It can also be voice disorders. They can have some type of paralyzed cord or a difficulty actually bringing their cords together to communicate or to produce verbal speech, and aphasia, which we had mentioned in the beginning. So at this level, the goals tend to go towards that ultimate goal of independence, like I was mentioning. During previous stages, emphasis has been on communicating basic wants and needs. As people advance into these higher RANCHO levels, however, the scope of their communication increases to include participating in social conversations, like Erin was talking about with Apollonia. So chit-chat, more turn-taking, where it's kind of a back and forth in conversation, and providing more specific information. For instance, providing details on medical care, asking questions, etc. Additionally, in these stages, people are often interested in expanding the reach of their communication. And this would be things particularly like remote communication. So texting, emailing, being able to video chat with loved ones. We also are working towards improved efficiency during this stage. No matter what, AAC will always be slower than verbal communication, just by the nature of it. We have to wait on people to make their choices. If they're literate, which most people in this group are, they have to take time to type out a response. And even with tools like word prediction and quick messages, which are things that we're training at this stage, it will always be slower. So the more efficient that we can make them with those tools, the better. And then, of course, just overall independence with communication. Okay, So this gentleman that we're going to talk about, we're just going to call him A. He is, or was, a 26-year-old male. He came to us after a car accident. His brain scan showed that he had diffuse axonal injury as well as bifrontal contusions. And what's really interesting about his case study is that while he was with us, he actually, I'm giving him as an example of a Rancho level 7 through 10, but when he admitted to Craig Hospital, he was still in that Rancho level 3, that minimally conscious state. And in fact, we did not get consulted to see him for AAC until about 3 weeks to a month into his stay, when he started showing that he could have some basic command following and that he was starting to have some consistent volitional movement that he could start to use. Where we started with him, he was very techie. And so we kind of skipped over the paper type things and we skipped over some basic buttons and we went straight to an iPad because he was very familiar with that and worked in tech. And in the beginning, he really needed very concrete pictures. And so we took pictures of his actual things and put a word with it. At this point, we really weren't sure if he was reading or not. And so we started here with just one basic page, like at the top, that had 4 of the most basic needs that he was needing to request at that particular time. Eventually, we were able to move up and make some pages that had less specific pictures on them. And again, we still were not sure if he was literate. But very, very shortly after that, we finally were able to tell, okay, we can take those pictures away and he can handle just having the words on the particular buttons. And he finally got to a point, he had quite a few physical limitations as well as some visual limitations. And he did advance to where he could have 5 things on a page. Obviously, the buttons are still pretty large if you think about this being on an iPad. And he had multiple pages. So you only see one page here of his basic needs, but he also had a people page. He had a wants page, things that he might want to do for fun. And he was able to toggle through those pages to make his choices. So just keep in mind that as we're introducing these new forms of AAC, what this is also doing for us is it is letting us kind of evaluate his cognition and his language skills as we're going along. But without having an AAC tool like this, this would have been very difficult for his primary therapist and the therapy team to parse out where he really was with regard to language and communication. As he continued to improve, we finally, one day I just basically said, let's try a keyboard. And I gave him a keyboard with really large letters. In fact, I think we even started with a paper keyboard just to see what he would do. And it was very clear that he was trying to spell out some things. So we made some accommodations to his iPad that made it easier for him to interact with them. And he started spelling for us and spelling out answers to particular questions. And during this time also, when he started interacting with the keyboard, we were also able to assess using his AAC tools that he was starting to remember things day to day. He was finally remembering where he was remembering the date. And so this tool really helped us to see, okay, he is now emerging into that stage where he is laying down new memories and now into that Rancho level 7 section. With that, as he continued to improve, he was able to use more tools. So then we got good at using word prediction. He started video chatting with his parents. This was during the kind of first lockdown of COVID when we could have limited caregivers in the building. And so he started to really increase his scope of what he was able to do with the iPad and the ways that he was able to communicate with people who were both physically present and those who were not. He discharged home in June of this past year. At the time, he was still not talking verbally. He could make a few sounds, but was not talking verbally. But he was communicating pretty complex things with his device and was able to participate in conversation with his family and his friends. Okay, so that is all for our RANCHO levels. So now we're going to transition to a different population that we often see here at Craig. And this is our patients who are on ventilators or who are locked in. Here at Craig, this group is made up mostly of our folks who have high spinal cord injuries. For the most part, this group is cognitively and linguistically intact, but they lack the ability to speak, either due to being on the ventilator with their tracheostomy cuff inflated that prevents them from being able to speak, or because of their brainstem injury. This group may or may not have functional facial movement and the ability to mouth words, but at a very minimum, they usually have intact eye control. This group is almost always literate. There can be the occasional brain injury on top of a spinal cord injury, but traditionally this group is literate, which means that these people are often eager to get access to a keyboard so that they can communicate in whatever way they want in whatever situation, so they're not limited by single message buttons. Goals for these individuals center around finding the best access method. Most of these folks end up using eye tracking or head tracking for the quickest access because they are usually unable to use any other part of their body. The other goal that we address in this section is to determine a device that meets all of their varied needs. So obviously communication is always the number one goal, but what do they do to communicate with people outside of the hospital? How do they control things in their environment, like their television or their lights? And do they have a need for computer access? And what's nice is a lot of these higher level devices, what we call a dedicated speech generating device, can do all of these things. And so with this group, we aren't up against some of the cognitive challenges that we are with brain injury, with a traditional brain injury. And so we're able to address some of these goals even in the inpatient rehabilitation stage. So this is Miguel. I have been working with Miguel for 4 years now. He came to us as a 22-year-old male who had an anoxic brain injury. He was working and was carrying a ladder and hit a live wire and was electrocuted. And his anoxic brain injury was in the area of the brainstem. He was admitted to Craig a month after his injury, and at that point, his family had already figured out that he could use his eyes to communicate yes and no. So he would blink once for yes and blink twice for no. But that was really the extent of communication that he had at that time. He had no facial movement, but completely intact cognition, which we learned very, very quickly. The way that we started with Miguel was to see if there were any tools that we could give at bedside that would immediately improve his communication. And so the two things that you see at the top here, both a needs list and an alphabet board, we gave to him and to his parents and taught them how to use them. And basically one person would announce the topic, and when they got to the one that he wanted, he would blink. And then within that topic, they would read out, for instance, lights, volume, call light, shades. And when they got to the one that he wanted, he would blink again. And so we call that partner-assisted scanning. He eventually was able to do that with an alphabet board like you see here as well, where someone would scan through the options and then he would select the letter and would spell out anything else that he might need. So we started him off with these, but very quickly I knew that we needed to get him on a speech generating device that probably had eye gaze as an access method. We got a loaner in-house, and he actually ended up using that loaner device mounted on his wheelchair for all of his communication. His eyes, he had a few visual issues that we had to consider and work through, but probably by a month in, he was using a full keyboard independently. And so from that point, our goal was to see, okay, we need to figure out the right device for you and figure out how it can make you as independent as possible. And so when he left us in January of 2017, he had his own device for home use that we had scripted for him and received funding for. And he was using it for all of his communication with people in person, his remote communication with those outside the building, as well as controlling things in his environment. His device was able to allow him to change the TV channels. He had a couple of lights in his house that he controlled. So this was a really huge tool for him to become independent. And again, without having something like this, he would have been completely dependent on family for pretty much everything, even to anticipate his needs. We have also gotten to continue to see an outpatient. He has made quite a bit of gain when it comes to physical abilities. And just recently, I got to see him to reevaluate his device. And he has now advanced to where he can use, you'll see in the picture on the right here, he can use a much smaller device, which is great for portability. And he's got a stylus there in his hand. So he can actually now use his hand to be able to access his communication device. But he's still using the device for all of those things that I mentioned before. Okay, so to wrap up, before we take some questions, Miguel's a really good example of someone who we decided, okay, this is a good choice. We need to make sure he has a device to take home. That's not always the case. And so we just want you all to know kind of what the decision-making process is for us regarding long-term AAC use. Our goal, of course, or our hope is that people regain the use of verbal speech because, again, it's most efficient and effective, and it's what we're all, it's the goal of anyone who comes through and has lost those abilities. But having an AAC device may be a long-term choice for someone. So we're looking at things like prognosis. Often we're relying on our doctors for that. How have they performed with trials that we've done with them? Have we found something that really, truly works for them and that they can use either independently or have someone at home that can help them with that? Have they accepted that AAC needs to be their method of communication? Some of our patients try AAC, but they really don't get bought into it. They'd rather just kind of struggle along with some of the means that they already have. And that is definitely an influencer in whether or not we pursue getting a device long term. And then, of course, family and caregiver involvement. This is so important with everything in rehab, but particularly for our partner-dependent communicators. Do we have a family or a caregiver who's willing to do the setup, who's willing to be a communication partner for this person when they're at home? Okay, we have a bunch of references, particularly from the slides with our research. And now we'll take some questions. Thank you for listening and being a part of our webinar today.
Thanks, everyone. There we go. We'll go back to this just in case you wanted to share my